here with my friend Dr. Jerry Bailey, who is a prominent expert on men's medicine and leads the world in the emerging science of polyhormonal adrenal testosterone syndrome, aka PHAT, which I love. PHAT. He is an acclaimed speaker, former clinical and graduate educator, one of the few practicing experts, and is considered a leading authority on men's health. That's true. There aren't a lot of them. He holds degrees in chiropractic, acupuncture, and masters of science in human nutrition and functional medicine. His prior background to chiropractic school was in health promotion and rehabilitative and prescriptive programming, nutrition, and coaching from Central Michigan University. He has been in practice for over 2 decades, seeing tens of thousands of patients in that period. So welcome, Jerry. Thanks for coming.
Hey, glad to be here, Bridgit. Thanks for having me. Hashtag BBD, as we always love.
Yes. So Jerry and another friend of mine, initials are BBD, and they just can't seem to get enough of that for some reason.
Well, it's the old, old enough to remember Belle Biv DeVoe from.
Oh, that is what it is. I forgot what the joke was even about.
Yeah, that's the whole thing. You're the hashtag BBD,
Yeah, I still am. Still rocking it. Well, we have recently, we had a team meeting. I'll tell you a little backstory. And my social media manager was like, hey, we have a growing male audience. And I'm like, that's fantastic. Like, let's try to start talking to them more. So I think pretty much our first male blog about hormone imbalances came out recently, and I think we're going to be covering some of the same topics. So since you are definitely a rare bird of an expert on men's health, it really is sad.
I'm a very rare bird, as you can say there. Yeah, for sure.
I think women are so much more involved in their own healthcare and all that, and there just aren't that many experts on men's health. So I'm super happy you agreed to come on, and I did not know you had this new syndrome you had defined, which is PHAT, let me go read it again. Polyhormonal adrenal testosterone syndrome. So let's start out with what is that?
So, or PHAT syndrome, it's kind of the old adage too, if we're going back in time to Belle Biv DeVoe, pretty hot and tempting syndrome, I also call it there too. But it's PHAT syndrome. It's what I see in my men patients across the board. I'm seeing it more and more. More men are coming in with this. It used to be we thought hey, it was just, low testosterone, or it's just metabolic syndrome, or it's just cardiovascular stuff. It's just mental. We're getting older, and it's that's such a cop out of just saying one thing. And what we're seeing across the board in men is these really 8 key things that are going on with them. We're seeing insulin resistance. We're seeing increased body fat there. We're seeing cardiovascular issues. We're seeing sarcopenia or decreased muscle mass. We're seeing the maladaptive stress response. We're seeing the hormone imbalances too. We're seeing the brain dysfunction. And then again, we're seeing on top of that, not only digestive, as we see all this all the time, and you see it with your clients too, that gut permeability issues is once that happens, then it's across the board. We see pan-membrane permeability issues going throughout the body. So we see all these things come together in our men. And a lot of times docs well, it's just low testosterone. Here's testosterone. Well, they get 2 weeks into testosterone, they feel great, and then they start feeling bad again. Because it's not just one single thing going wrong with them. It's a multitude of things that we have to address. And often for men, as you said, women take charge of their health. Men tend to just I'm fine. And really what happens with men is they don't come in until they start noticing things aren't working the way they're
supposed to. I was going to ask, what is the tipping point or the lack thereof?
There's a lack of tipping up point there for them that happen. And that's usually what draws them in to coming in and getting care done or figuring out what's wrong with them. So those are really the main key tenets of PHAT syndrome that we look at and go on and fix for guys.
Okay, I want to dig into those 8 things more. I couldn't quite get all of them written down, but I could kind of get a sense of what you're talking about with the blood sugar, the stress, and that that's part of erectile stuff too, can be blood sugar issues, right? Totally. You threw out another acronym that we could start now, which would be PBP, which is polybarrier permeability. Yeah. I like that one.
Pan-membrane permeability. So
pan-membrane.
Same thing as poly. So once you have, just leaky gut itself, it's a very common thing to see is leaky gut or intestinal permeability, depending on which side of the fence you want to talk about. Same thing. So once you have leaky gut, and we see this in men, there was a study done several years ago that actually it's called the gelding theory. So just like male horses that have been castrated, they're called geldings at that point. So what they see in this research was with dysbiosis in the GI tract itself, in the gut, or any kind of microbial change, you'll get that leaky gut, those cells pulling apart, and then inflammatory and immune responses occurring. Well, once that occurs, there's certain bacteria that actually affect testicular membrane and prostate membrane too. So we'll get leaky testes and leaky prostate, and we'll see the PSA go up in men, and we'll see testosterone go down in men in that scenario. So once we have one membrane leaky, typically the gut, then we get it across the board throughout the body.
Yeah, for sure. I think that's a really good like learning point. And then for the brain too, then if people like aren't thinking as well, they feel like they can't, they're like, oh, I'm getting old. Right.
Got the brain fog, things don't work the way they used to. My heart's not working. So yeah, once that pan membrane or multiple membrane permeability issues occur.
So Jerry, I know with women, and we go through menopause, and the type of or estrogen we use changes, and that can like affect our brain, at least temporarily, as we're like, our brain's trying to figure that out. Is that happen with our men too? Like, does testosterone impart? Okay, tell us more about that.
Yeah, testosterone is definitely a definite part of brain function and nerve function there. So is estrogen in men too. We need a little bit of testosterone in men, or a little bit of estrogen in men to help with brain function. But what happens with this syndrome, and we see this in middle-aged men too, is testosterone goes down, estrogen goes up. And so that increased estrogen in men is actually neuroinflammatory. So we see the brain getting more inflamed. We see more of the memory issues come up. We see that earlier onset of dementia, Alzheimer's occurring within that process. So we see those things occurring, and it's just that shift balance. We see it different. Women will go a little high estrogen and then drop, but that testosterone in women can elevate and cause neuro stuff too. But it's the men we see that drop in testosterone, increase in estrogen. So men produce normally a very small amount of estrogen in our testicles itself, where most of the estrogen that gets converted from testosterone to estrogen happens in fat cells. And so the more adiposity, the more fat we get as guys, the FAT, not the PHAT, the FAT in guys, that's when we start seeing elevated estrogens occurring more so in men. And then that wreaks havoc in and of itself on the body in multiple ways.
Okay. So is that the aromatase effect?
Part of the aromatase, yep. But it's also in the fat cells itself. Like we can block aromatase to, that testosterone to estrogen conversion, but eventually it's going to get overridden. It's going to be more and more aromatase inhibitor, whatever one you're using, is going to increase and increase and increase because of the fat cells producing more estrogen.
Oh, super interesting. Okay. So I know we're going to kind of talk about testing. Let me see what else before we get there. Okay, you were saying, I'd love to go over just more like the 8 things, like break them down a little bit more. So I think the first one you said was insulin resistance, right?
Yeah, the insulin resistance that occurs. So insulin resistance, once we think of the cells of the body like a basketball, and we have all these little receptors on the cells that are taking in information, whether it's like insulin or testosterone or thyroid or other chemicals or hormones in the body. Once those cells change metabolically and we have less receptors on there, and it could be an insulin receptor, it could be a thyroid receptor, it could be a testosterone receptor. Once that changes the metabolic activity of that cell. So then we start seeing the cells start to shut down even more and become more metabolically inactive. So insulin resistance occurs, and we can, you can take some of the insulin resistant medication or the insulin medications, the ones for type 2 diabetes there, and they just stop working because the cells are shutting down. You can only force it for so long till the body finds another way around it. So that becomes more and more medication that has to be happening there. So insulin resistance is a big key, or glucose resistance is a big element of this, because what we see in today's society is in men is we're inactive, we're eating poor, and the body is just in this dormant state.
Okay, so that's what I want to ask you about. We're eating poorly, we're inactive. So the body's trying to slow down the metabolism, more or less?
Yeah, it doesn't, its cells are usually full already with glucose, with other nutrients. So they don't need any more. So they just shut down receptors. Once you shut a receptor down on a cell, it starts going, oh, I don't need to be as metabolically active. It starts shutting down other receptors too.
That's a great point. That's super interesting. So I'm not a man, as you may be able to tell, but I'm a middle-aged woman who works at a computer a lot. So I've had to kind of like learn to, and I'll just share what's been working for me. It's probably similar to guys. just as far as lifestyles, I'm really being good about not snacking. That's
Yeah.
a huge help for me. And then kind of intermittent fasting. I usually say more like time restricted eating. Like for me, I prefer to have a really late breakfast. I know other people kind of go the other way and eat early and stop sooner. And I definitely am moving more, partly because for, like back pain and just keeping like active. And then like if I'm working for a while, like go to the gym in the middle of the day. I think I've always kind of wanted to be active, but some people didn't grow up with that, or they're in a job that like really there's a lot of sitting or commuting, so it's tough. So what do you advise for men?
Well, sitting is considered kind of the new smoking.
Right.
Yeah. So that sedentary lifestyle, that non-movement lifestyle, really is a major cause of a lot of health problems. So people, getting a standing desk is helpful. Getting a ball chair, a chair that's the ball, so they can move around. That's very helpful within there. And making sure they're getting up and moving around throughout the day. And then at the end of the day, often they come home, they're like, oh, I'm tired. I don't want to do anything. You got to get out and walk. You got to get out and move. You got to make that body and those cells want to be active and want to pull nutrients in. When you don't, then we see that occur. It's just that domino effect across there, that sedentary lifestyle, increased insulin resistance, increased adipose tissue, developing less muscle mass. So we get that sarcopenia, essentially that loss of muscle mass there, which feeds into more fat mass. I mean, it goes down through the 8 tenets here for fat syndrome. It's just that domino effect that we see happen for people.
Okay, well, let's talk about loss of muscle mass since you brought that up. So that's just partly from lack of exercise and then the cells kind of shutting down as well?
Yeah. The lack of exercise definitely happens for a majority of people. And so we have that decreased muscle mass. Research shows that the more muscle mass we have as we age, the healthier we age. It used to for a long time, it was thought as the cardiovascular. Like, you got to have this cardiovascular, this amazing, endurance heart and endurance body for health long term. And the research actually shows that long-term cardio and what they call chronic cardio is actually detrimental to the body. It's actually worse. Whereas the more muscle mass we have, the healthier we age, the healthier we have, the less issues we have as we age, because the body is more metabolically active. Muscle mass equals metabolism.
Yeah, I was talking to a friend who's doing this long bike tour, and he was like, well, a lot of the guys have like big bellies and they drink a lot, and it's like kind of looks like a lot of exercise, but it's sort of also not. So maybe it's, if you're going to cycle, also you got to watch the beer drinking and like hit the gym, sounds like.
Yeah, you got to get muscle mass and lift weights and get stronger. For women also. And the more muscle mass women have and you ladies, you won't get bulky. You won't, women think like, if I lift weights, I'm going to get big and bulky. No, the women that I know that I do CrossFit with and everything else, they're not big and bulky at all. They're thin, dense muscle, not heavy at all. They're not bulky at all and they lift weights regularly. Some of the stuff they do, they actually lift more weights than I do in certain exercises. And I'm like, okay, ladies, that's fine, because my body's not designed to do that movement. But it's the more muscle mass they have, the healthier they are long term.
Yeah, we're having Dr. Gabby on our Mold Summit. I'm super excited to kind of talk about that concept. And I find a lot of my female clients will be like, well, I walk or I this or that, and maybe they're not comfortable lifting weights. Luckily, I was sort of raised to lift, or my coach would make us go in the weight room. So I had some exposure to like not feel, and you can always get a trainer, or do different programs. Our friend Deborah Atkinson has a program. Our friend Emily has a program. There's a lot of exercise programs for women out there. So those are actually all in our archives of this Facebook Live.
Lean mass is essential. Getting strength is essential. Don't be afraid to move beyond the 2.5 pounders, that are at the gym. That you always see the one person, just the 2.5 pound dumbbells are just lifting forever there. It's like, you can go up in weight. It's okay.
Yeah. Although I think like if you're not recovering well, you don't have to go up crazy amounts of weight either. Like I'll sort of do like warming up my joints with like little 3-pound dumbbells and move to 5, then move to 10. And then I'm kind of like good, it's enough weight for me for a lot of activities. So Pamela's asking about being skinny fat, which you may know that term better than me. She's saying lifting weights, but still being skinny fat. Is that a detox issue?
It potentially could be a detox issue there. Again, it's going to be per person, what's going on and what that cause is of that skinny fat. So skinny fat is literally like you see a person, they look really skinny, but they don't have any muscle mass. It's mostly fat mass that they have on their body. So that's
okay.
just as unhealthy as a fat person, I guess you could say, there, who has that obesity in their body. They're severely overweight and it's still fat mass that they have.
That's a good point. Yeah, there are people like that who are just almost a little bit like frail-ish, so to speak. Even some men.
Just the skinny fat, so to say, in that process. So
what?
There you go. Again, go ahead.
I was just wondering, what does the muscle cells itself like do for us? What's the benefit?
Well, it moves our body.
Yes.
And it creates the scaffolding to keep our body moving there. So they attach to the bones. The bones don't keep us moving. It's the muscles that keep us moving. So,
I meant like when you said the most important thing for like longevity is like having this muscle mass. Is that just like keeps us from getting injured, burns calories? Like, what is it doing?
Keeps us from getting injured, keeps us strong and stable, keeps our equilibrium down better. It increases our metabolism through there. That's just 4 simple points of what muscle mass does. And it gives us a reserve. Okay. It gives us a reserve that happens if we get sick, if we get injured in some way, we have a better chance of recovering from that because we have that muscle mass there. If it's just fat mass, that's just necessarily, it's active tissue, but it's not metabolic tissue. So fat mass, having a lot of that, does not give us a reserve for strength and for health, whereas that lean mass gives us that reserve for health.
Okay, awesome. So I don't remember all. So do you want any other of the points, the 8 things that we haven't covered that you want to get into?
Well, I think for sure looking, again, it's that domino effect there that we see across the board for people. We'll see the cardiovascular issues. We'll see the maladaptive stress response. I mean, stress is such a huge factor, and understanding how that stress response is occurring in the body is essential to know how you're adapting. Because if you're not adapting, that's a major issue there for itself. When the hormone imbalance is there, we see that as a lot of guys will come in, they have kind of slightly lower testosterone, and they may have went to another physician or a testosterone center and got testosterone given to them, and they feel worse. And it's like, well, it's more of a metabolic issue. Pardon? Like
anxious, or how do they feel?
They'll feel anxious. They'll feel they'll increase blood pressure. They'll feel depressed from it also. They won't feel good. Like if you're taking testosterone as a guy, you should feel good from it. Like you should feel good, more vibrant, more healthy. If you're not feeling that way, it's the wrong dose, or it's too high, or it's completely wrong for you. And often docs will just look at testosterone in the system and not understand that they might have low testosterone, but the free testosterone is in the normal range. So we always look at testing and going, not just what's there, the total testosterone, but what's the available testosterone. So that free is really important to run on nearly all hormones to know what's available and how you're going to use it. If it isn't there, you can have, I've seen patients, guys with normal testosterone or elevated testosterone total levels, but they're free or in the tank. And so you're just looking at the total. They're like, well, you're fine. Well, no, they're freeze bad. It's kind of like thyroid, looking at, TSH looks great, T4 looks great, but T3 is in the tank. Well, T3 is your active form. So it's that same process of digging deeper to understand what's going on with those guys there. And in fat syndrome, we look at all that process there, run the testing to figure out what's going on and find the underlying reasons, correct it. A real simple test that I have guys do, or most guys do, to really see if fat syndrome is going on for them, is I call it the look down test. And literally they turn to the mirror and they can see the mirror from the side and they look down. If they can't see their penis doesn't want to look up at them. So they're going to have erectile dysfunction issues. So, it's really like, if you can look down and can't see it, it doesn't want to see you. There's major health issues going on for them.
Oh, okay. So the maladaptive stress response, are you saying that's more as a result of the hormonal imbalance, or is that more like you're having a stressful life?
Stressful life, for sure. And that's majorly what we see, versus that being an issue in and of itself. It's the stressful life. It's the things going on in their world that's causing those issues. That's causing the stress response to no longer function the way it's supposed to. It used to be called, or still gets called, like adrenal insufficiency, adrenal fatigue. And, there's always that argument there. But if you go into research, you can actually find the data on maladaptive stress response.
Okay. Okay, interesting. So you find that people who come in and sort of really, feeling like, okay, things aren't working right. Do you feel that like their lifestyle is so stressful or busy or what have you, that that's why they're kind of eating these convenience foods and not exercising? Or is it just sort of like culture has taught them to do that? What do you find?
It's a combination of all that, really. Again, it depends on the person, but it's making choices. We have done, medicine has created a thing where personal choice is gone. Like you just go in, get a pill because you're feeling bad, and you're there you go, you're fine. Well, that's taken away that personal responsibility. And really in today's times, we need to really empower that nature of taking a responsibility for ourselves and taking care of our health. And so often guys just like, well, I'm just going to stop and eat because it's easy, or I'm just going to go do this. And their lives just start falling apart from there. They start feeling bad. They get depressed. They get the anxiety within there too. They start gaining weight. They start losing muscle mass. They start having little mental issues go on. They start they start having problems in the relationship. They start getting issues that they notice, like things aren't working the way they're supposed to. They're increasing the fat mass around their abdomen. The belly's growing, but the pant size stays the same. It's like, yeah, I still wear the size 32. Yeah, but that doesn't include the 10 inches hanging over the gut there. So you're not really in size 32 pants anymore.
So it's just kind of progressing without them realizing, it sounds like.
Yeah. And they just kind of, life gets in the way of living sometimes with them. And it's like, we need to make that conscious choice and coach the guys and gals through it of like, hey, you need to make choices here and make better choices for your health, or you're not going to be around.
Yeah. Okay. Awesome. So you have a free gift. I put in the notes here. It'll be under all the videos. It's about what labs to run and what levels like those labs values should be at. I just signed up for it, Jerry.
If you go to thefatsyndrome.com, I have that download there of good labs to run for yourself. And you can order those yourself. There's a lot of good lab companies that do that on your own. You can go to your doctor and go, hey, I want these labs ran so I know what my levels are. And sometimes docs won't know. They just don't understand beyond the basics of what to run. And some may refuse, but you can go to great lab companies online and have them run yourself.
Okay. I think I don't know if it comes in a multi-day thing, but this first handout is about 7-day amplify.
Yep, that's one of them. And then there should be an attachment on there also for the labs itself too.
Okay, gotcha. I just thought we could maybe have a visual to share. So you're talking about blood labs or
blood labs for sure, yes, because the other additional functional medicine labs, those are more need a practitioner to really go through those. Like the Dutch test that we use to look at there, for an example, those you really need a practitioner to go through because lab values will vary greatly.
Okay. Well, why don't we start off talking a little bit about the blood labs, and then we can go talk about the Dutch test. So you're saying blood labs potentially run on yourself or ask your doctor and then kind of check your guide to see if you're in range?
Yes. Yep. Check your guide to make sure you're in that optimized range. When you look at blood work, it's usually it's based on healthy and unhealthy individuals. So the range is gigantic. Now, when we look at functional labs and functional blood work, we want to go down to more of a narrowed range in there to know what's really optimal functioning there. So the handout will be there. If it's not there, it's messed up in the process of the download there, but I'll get that fixed for everybody for that. But that will show the narrowed ranges of where optimal function is versus the general population, which is really a huge range that means absolutely nothing.
Yeah. Well, maybe for the sake of visual, I'll pull up the Dutch test too. We're doing a sale on Dutch test this month. I know you run the Dutch test. Yeah. So we are encouraging more men to show up. Sometimes that's through, women encouraging their husbands, let's be honest.
Encouraging their husband, encouraging their boyfriend,
Yeah.
They notice, because ladies, you notice when things aren't working before we do usually, because we're fine, quote unquote, So if you're noticing it, I always say use the size 12 to push them through the door to get into an appointment.
So let's look at a male sample report. Let me see. Dutch sex hormones. No, Dutch complete. Let's see. Male report. What was I going to say? I think when I used to work in fertility a lot, there'd be a lot of shame around fertility, and I think it could be the same, I'm imagining, with erectile issues. It's like you feel like embarrassed and you don't want to. It's a medical situation. Like We don't feel, we don't judge people for having cancer or any, like, it's just a situation that's developed. So I think it's probably part of that cultural thing too, that we haven't been trained to think for ourselves and like research and try things, like be proactive in our health. So then when these situations arise, we feel, embarrassed instead of just being like, that's odd. What's going on here? So the Dutch
Well,
test,
as you brought up fertility, 50% of fertility is the guy.
It is. They don't like to think that. And sometimes they go to the conventional doctor and they say, well, he said it's fine. And it's just like you said for the blood labs. It's like fine compared to what?
Yeah,
so
exactly.
Yeah, and often the wife is doing so much work. And if the guy is just like, well, I don't have to do anything, it's just not really fair. Like both parties should be optimizing their health.
Totally.
Okay, so here's an example male test. I don't know, Jerry, do you want to show some things you look for? Like,
well, with guys, with guys, we're going to look at that estradiol there, right at the top, and testosterone there. Now, remember, this is down metabolite a little bit, so we're not going to see, like I had a gentleman this morning who is on some testosterone. His total and free testosterone in the blood looked perfect. And so it wasn't super elevated. It was right where it should be. When we got on this test, his testosterone was severely above that 115 level, I think is what it is there. Yeah, 115 on the Dutch. So he was like, well, how come the blood work looked that and this looked different? I said, well, this is looking at what you're excreting from the system. So you're excreting that out. So it was still totally normal within there. So we like to see kind of the mid-range here for most of these labs there for men and women for the most part, looking at there. We look at the cortisol response and see what it's doing. Now, this one doesn't look horrible, other than this person, I would say, at night has a hard time sleeping because of that nighttime elevation there.
Yeah, exactly.
Hard time getting to sleep. Keep on scrolling.
Yeah, we can maybe skip this one, or do you want to look at
keep going, go to the estrogen. So here we'll look at there. So this person has a high level of DHEA. So they might be taking DHEA when we see it that high there. As usually I ask, are you taking DHEA? Testosterone looks good. And surprising, like the cortisol looked good. So the DHEA was a little bit high. So to me, this person might be on DHEA itself. As we go to the left side in the metabolites, they're a little low, but, again, not knowing what their blood testosterone was and their free testosterone, it's hard to say. I would like to see this one, that last little one where it says the 5-alpha reductase activity, the 5-beta versus the 5-alpha. I would like this person shifted over to that 5-alpha. Yeah, right down there, over to that a little bit more than sitting over on the left side towards the 5-beta there, because 5-alpha is more androgenic in men. So this one, there might be some issues going on with them. They might be a little fatigued. There might be a little low T type senses issues there. As we look at the estrogens itself, like the estrogen levels, the estrone is a little bit elevated on the higher end. The other ones look good. If we look at their metabolites, the 2,4-16, those actually look pretty good. Just like in women, I'm sure you've covered it with your ladies too, the 2,4-16 ratio for cancer risks with the 4 elevation or the 16 elevation, we look at it the same thing in men, because men can have estrogen-based cancers. Incidentally, the research is showing that prostate cancer itself is not typically a testosterone issue, it's an estrogen issue.
Okay.
And so the whole thing of cutting testosterone out of men and giving them the testosterone blockers and basically feminizing them isn't increasing life expectancy from prostate cancers at all. It's actually making it worse. So, knowing those levels is key to know, do we need to put some estrogen blocker in here to get that conversion back over to the 2? And this person here has some low methylation. So looking genetically, do they have some methylation issues along with some other glutathione type issues that we need to fix so they can methylate and detoxify a little bit better for themselves too?
Yeah, I love this page. It gives so much information in one page about how you detoxify every kind of level of the hormones, and some of these little tweaks that Jerry would know how to make in his practice. Again, going to some testosterone clinic, they're not at all going to be able to
care about this at all. They're just looking at your total testosterone. That's it.
Yeah, they're just like dropping a little testosterone bomb and then seeing what happens, which, as you said, isn't always a fit for everyone. So,
and you're going to feel good for a short period of time, but then it's going to need more and more because your body isn't adapting correctly.
Yeah, so interesting. So that page is really helpful. This page is a little boring unless you want to put anything.
I always say, like, these are numbers. We'll go over the pretty pictures. It's a lot.
Yeah.
Yeah, here again, this doesn't look bad. The melatonin is actually at a good level for the person. Cortisol, cortisone, this looks pretty darn good. I always go to that last one, which is the organic acids portion of it, and kind of see
Yeah, that's just a better
a
page.
little bit more. And yeah, here again, pyroglutamate, that glutathione marker, a lot of people are low. And in today's society, with everything we see in exposure, glutathione, our master antioxidant, is super low in most people. And so we'll dose either injection or IV glutathione for people to bypass gut, because glutathione isn't greatly absorbed. Liposomal form is much better absorption, but the other forms are not. So we'll go straight to injection and IV for them. Their markers for B12 look good. The methylmethylate, the xanthinurate and kyurinate pathways look pretty darn good here. So the B6, that's neurological issues there. Dopamine on the low end. So this person probably is not like supercharged in life. Dopamines are good, feel good hormone in the brain. And they got pretty low end here. So they probably just feel kind of meh in life. I always call it the meh syndrome, like, how do you feel? Meh, I get up, I go to work, I come home, I go to bed. So we're seeing some dopamine issues. And then again, surprising with their stress response was a little bit cattywampus there in the beginning there, that cortisol curve. So not surprising, this is a little bit on the low end too for them for that. So addressing that cortisol response, and then we've really good the stress response, that maladaptive stress syndrome we talked about as one of the key tenets of FAT syndrome. But here their oxidative stress, so the actual cellular inflammation, is like I call it, in the cells themselves. This 8-hydroxy-2-deoxyguanosine marker is a marker within the cells that break off when the cells break apart from damage. And this is on the lower end at 2.8. I'd like to see this around 6. So they have some oxidative stress or some stress in the system that's causing some issues. So here a person would benefit from a little bit of antioxidant therapy on top of the glutathione to help them get better. Usually a short dose, 2-3 months of an antioxidant I would give them, but they'd be doing weekly injections or IVs with the glutathione, which would help that even more so.
And you're in Idaho, right?
I'm in Idaho. Yeah, I'm in northern Idaho, and Coeur d'Alene is where I practice.
Oh, it's so pretty. I didn't realize you were there. But you work on Zoom as well, or no?
We do. I do telemed also with clients. Work Zoom wise to help them, figure out what's going on with them and figure out their health and get them better. Yeah.
So. And you can prescribe hormones as well? Hormone replacement?
I do not prescribe hormones. I'm unable to as a chiropractic physician. But we would typically see my wife, who's a naturopath and acupuncturist that has prescriptive rights. She'll see them. Or if they have a physician in the area, if we're working telemed wise, that they're working with, that we can have them prescribe the testosterone for them if they need it to help them get better.
Perfect. So yeah, we do run the Dutch in our clinic, or our practice. But if you want to kind of utilize Jerry's brain, especially on men's health and erectile issues, he's got tons more experience with that. Or if you're in his area, even better. You can go, and it's so fun to get all those in-person treatments for sure. So
yeah, because we'll incorporate acupuncture, chiropractic, IV therapy, injection therapies. Supplement therapies, dietary stuff, lifestyle. So we do all that to really, what's the cause? That's what we always try to find out. What's the root cause here? And this fat syndrome has developed because we're just seeing domino effects in men's health and women's health. It's very similar to PCOS in women, but this is in men, it's called fat syndrome.
Interesting. And did you make that expression up?
Of course I did.
Oh, I like it.
Because there's just nothing out there. There's just nothing out there. Men's, just like most medicine, everybody tries to get it down to one little thing. And and it's like, that's not reality. It's not one little thing that's the problem. And so, just like PCOS is multifactorial, fat syndrome is multifactorial. Yeah,
100%. So I like how you're kind of putting it together, though, in this kind of grouping that people can understand. Otherwise, people could get kind of frustrated, like, well, I already did this and that, and why do I have to do more stuff? You do.
Yeah, you missed something in there, and the doc wasn't looking deeply to go, what's wrong? I mean, even on this level here is, when I'm looking at somebody, I use I like acronyms. And when I taught, I use acronyms because it makes it easy to remember stuff. Instead of trying to remember all these words, you can just remember a word that makes up each of the things. So when I'm working with somebody, I'm trying to finesse, with a D at the end, finesse their health. So I'm looking at, is it a food issue? Is it a infection issue in the body? Is it a nutritional deficiency? Is it endocrine or hormone issue? Is it stress? Is it structure? So is it a cellular issue? Is it a spinal issue from a chiropractic perspective? structure of the cells itself? Is it environment? So detox, is it environmental detox issue? What are they exposed to there? And then also D, is it genetic? Is it the DNA that's an issue for them that's causing the problem for them? So I like that acronym myself, the FINESSED, FINESSED, because it gives me a good route, pretty much like everything's in there. There isn't anything that could be wrong with them. Yeah, finesse. I've used that for a long time. I talk to clients through that, and they're like, "Gosh, like, what do you not hit with that?" And I'm like, "Nothing. You cover everything."
That's a great point. And we just looked at the Dutch test. It's a great test, but sometimes in isolation, it's just still not quite enough, right?
Yeah.
We don't know the barriers. We don't know the gut health. So we can't always have the money to run like every test at the same time. But it is nice to have 2 or 3 so we can be like, oh, this seems to be causing this and da, da, da.
Yeah.
So it's really helpful.
I mean,
right?
there's kind of 4 or 5 major things we like to run. Blood work, of course, depending on what's going on, and that can mean a lot of different things. Dutch test for how you're metabolizing hormones and the smell and the stress response. Organic acids testing to know like how your body's working, okay? Because blood work tells us disease, OAT tells us function, Dutch tells us function. I use the gut zoomer personally, and in our clinic we use the gut zoomer from Vibrant Wellness. I like that one. It gives a wonderful report. And then we look, those are kind of the base 4, and then we look at genetics itself. We look at genetic testing and epigenetics to know what's going on genetically with somebody. So those 5 things give us a lot of information. And, sometimes we can pick those and do a couple. Sometimes we're like, you know what, let's do these 2. Let's wait on these, put those in the back burner, bring them in. But ideally, if we could run these 5 tests on everybody, we could nail you perfectly and be able to go like, here's what's wrong. Here's how we're going to fix it. And here's where we're going to optimize your health from here on out.
That's a great point. Yeah, wouldn't it be so nice if we could just run this on everybody, because it is pretty revealing what's going on.
And a small investment here really, is in the relativity of health. Running these tests is cheap.
That's a good point also. Yeah, because
running all of these, you're looking, depending on the costs, and I mean, you're looking at a couple thousand most likely to run all these. But that couple thousand spent is going to save you tens to hundreds of thousands of dollars in potential health or disease cost care versus fixing the problems and getting yourself healthy.
Yeah, and just with quality of life cost of, just not being able to do the things you want, being meh, like you said, it's just like not worth living.
How many people do we know are just, that's their life is meh?
Oh, 100%. I'm in the suburbs. I feel like I'm like, get me out of here.
Yeah, it's like, meh.
Yeah, it's just kind of a routine. So, you want to kind of be beyond all that. So anything we miss.
Let's rock and roll in life.
Let's be fat. Wait, don't be fat.
Don't be well, be the other fat, the pretty hot and tempting.
He's a good fat. Okay, now I got it. That works better. Anything we missed, Jerry, that you want to cover?
No, I think we've nailed everything there. Had a great conversation with you as always. My hashtag BBD, yo.
Yeah. Thank you so much for coming on. Yeah, and we'll put all these resources. And if anyone's watching this later and you're like, somebody who needs it, pass it on. Again, there aren't a lot of practitioners doing men's health the way that Dr. Bailey does. So he's just a great resource to have in your pocket for somebody.
There's a lot of people talking about health. There's not a lot of people talking and doing health.
Like themselves personally? Yeah,
I mean, they're practicing it. A lot of people will have great ability to talk about things, but they aren't practicing it with clients.
Yeah, and you've got this robust practice and all
that's a huge thing is, you've been to a million seminars and you ask the experts like, hey, okay, you're saying this, but we tried that years ago and it doesn't work. Well, that's what the research says. It's like, well, that doesn't fit clinical practice,
Yeah.
So having a person, that's what I like to pride myself on in that sense is I'm a practicing expert. Like,
right.
I am taking what I see at seminars and implementing it in practice and going, okay, this is not this works or this doesn't work. And then how do we get this better? And then going back and going, you need to research this and go through this better, because this is what we're seeing clinically with people, not this other thing. And so that I always say that practicing expert is a much better expert than the person who's just an academic expert.
Yeah, that's a great point. That's a great point. Well, thanks again. And thanks for everyone watching. We'll try to get our reminders fixed by next week. Can't remember. I think we have water testing coming on. So that's another root cause. It's what's in your water.
Ooh, that's a big one. That's a big one.
It's going to be really good. Thanks again, Jerry. Thanks, Lee,
Thanks
for being
me.
on. Bye.
Yeah, thanks for having me.